Bueno, hola, buenas noches a todos. El día de hoy estamos con el doctor David Weber, quien nos va a hablar del abordaje de salud ósea en el paciente pediátrico. Good evening, everyone. Hi, doctor. Thanks for meeting us. I will make a small introduction about you. Dr. David Weber is a pediatric endocrinologist and bone health specialist in the Division of Pediatric Endocrinology and Diabetes at the Children's Hospital of Philadelphia and assistant professor of pediatric at the Perelman School of Medicine at the University of Pennsylvania. He is medical director for the Center for Bone Health at CHOP. He is an active clinical researcher working on studies in people with primary and secondary skeletal fragility and rare disease of bone mineral metabolism. So, Dr. Weber, it's all yours. Let me know when you are ready.
Thank you. Thank you for the nice introduction and the opportunity to talk to you all. All right, so I have a clinical talk for you, the clinical approach to the child at risk for skeletal fragility. Just a couple of disclosures. I do some consulting for companies that are involved in the rare bone space you can see here. So my objectives for the talk, I'd like you all to be able to recognize the spectrum of children at risk for severe skeletal fragility, be able to develop an approach to the use of DEXA and other imaging modalities in the clinical diagnosis and management of these children, and then become familiar with the standard of care and emerging treatment approaches to improve bone density and bone strength in children. First, I thought I would just start with an overview of what type of patients are at risk for severe skeletal fragility. And it really is a very wide spectrum. One way to think about it is splitting them into two groups of primary and secondary skeletal fragility. And so primary fragility are going to be those kids with the genetic disorders that affect bone structure or bone strength. The classic example of this is going to be osteogenesis imperfecta. The much more common conditions fall into the secondary category, and there's really a wide variety of chronic diseases, there's sequelae, and the treatments that can weaken bone. These cases are often actually tougher to manage because the conditions are often multifactorial, lots of different medicines, lots of different comorbid conditions, and this really makes up the majority of the patients we see in clinic. So let's talk about this group a bit more. It really does span the entire spectrum of pediatric subspecialties. So one nice thing about being in bone health is I get to work with nearly all the different clinicians across our institution. These children have a really heterogeneous pathophysiology of their primary disease, and they have a lot of different risk factors for bone health. One thing that's really important to understand when approaching these children is to understand what their clinical course is going to be. If it's going to be transient, such as might be the case in a child with acute lymphoblastic leukemia or ALL, where we expect them to be cured, we're going to be less aggressive with our treatment versus someone who has a persistent but stable condition, such as cerebral palsy, who's may not be getting worse, but the bones aren't probably going to get any better. And then finally, the most severe form would be those kids who have a persistent progressive condition. Duchenne muscular dystrophy, or DMD, is a good example of this. These are patients who lose muscle as time goes on, and as they lose muscle, their bones become weaker. So these are patients who we're going to be much more aggressive in terms of planning our treatment. Over here on the table, you can see just the sort of wide variety of the different diseases and different conditions that place children at risk for impaired bone health. The ones that we probably see the most of who we see in clinic would be those with chronic immobility, those with chronic inflammation, and then those exposed to high doses of steroids. And even though these conditions are quite diverse, there really are some shared risk factors here. So I always like to start in the middle here with fracture. And there's really two main pathways that get you to fracture. One is deficient bone accrual. So during childhood, we're expecting these kids to build bone mass until about the age of 20. And if there's something interfering with that bone accrual, their bone mass is low, and that's going to weaken the bone. And the second is going to be all the factors that impair bone quality, and that also reduce bone strength. And the factors that we sort of walk through in our minds when we're seeing these patients, we want to know, is there diminished bone loading? This can be from muscle weakness or immobility. What about nutritional deficiency, both in terms of macronutrients like calories and protein, but also the micronutrients important for bone like calcium, phosphorus, vitamin D. We want to understand what bone toxic therapies are being used, steroids, anti-epileptic drugs, hormonal contraception. And then, of course, we want to think about any endocrine disorders that might be affecting growth and muscle strength, such as a growth hormone deficiency or a pubertal delay. And then finally, thinking about those sources of chronic inflammation, which weaken bones directly. Next, just want to kind of talk a little bit about how we define osteoporosis in children. It's really a bit different than adults. In adults, osteoporosis is based on a loss of bone mass, whereas in children are still gaining bone, so they haven't even achieved their peak bone mass. And so the way that we think about it is that it really is a condition of failing to achieve the peak bone mass and bone strength that would be expected for that child. And so our goals of a definition really are going to be to identify those children who are with and at risk of clinically significant skeletal fragility for intervention. We want to avoid overdiagnosing and over-treating typically developing children, remembering, of course, that fractures are quite common in childhood. Somewhere between 20 and 50% of all kids will have a fracture. The current definition you may have heard of, if you've heard of any, it comes from the International Society for Clinical Densitometry, or the ISCD. And this definition states that osteoporosis in a child can be defined based on the presence of a single vertebral fracture, assuming that happened in the absence of trauma, or a combination of low bone density on a DEXA scan, defined by a z-score of less than -2, and 2 or more long bone fractures by age 10, or 3 or more by age 19. We'll talk a bit more about bone density, but it's important to remember that having a bone density z-score above -2 does not rule out skeletal fragility. And so this definition has been around for actually most of my career, so probably 2-3 decades now. It is appropriately conservative, and I think it does a good job of avoid over-treating that healthy child who has a fracture playing sports. It works okay for the more severe primary bone disorders such as OI, but I think it probably is too conservative for high-risk children. And it really leads to some undertreatment, I would say. So in some cases, if you follow this definition, you might be waiting until the second or even the third fracture to start treatment in someone we know is going to be at high risk. So in our field, there's really been a movement towards evolving this definition to giving a greater consideration of the risk factors for skeletal fragility beyond simply bone density and fracture number. So we're trying to move away from this idea of having a threshold-based criteria for either bone density or for the fracture number, and recognize that a one-size-fits-all definition is probably not workable across that entire spectrum of children. And so that single fracture is going to be weighted much more heavily in a child with greater risk factors, like a kid with Duchenne, than for a typically developing child with a forearm fracture. And here's just a paper down there that we wrote that kind of addressed these challenges. And ultimately, our goal is to identify and initiate treatment at earlier stages in high risk. So if you think about it, we don't really want to be waiting until after that first fracture. We want to be being more prophylactic. So now I want to move on to that clinical evaluation. So what do we do in clinic? And of course, like anything else that you learn about, it all starts with the key aspects of the medical history. The first thing we really want to understand is, what is that primary diagnosis? As I mentioned earlier, what's their underlying condition? Is that condition, is it transient? Is it stable, or is it progressive? And then we want to do a careful fracture history. We want to know not only the number of fracture, but the skeletal site, and then that mechanism of injury. So what did that occur in the setting of trauma, or was it atraumatic? We typically define an atraumatic fracture as one that happened from a fall of less than standing height at less than running speed. And then we want to ask about other musculoskeletal issues that may affect bone strength or mobility. Thinking about things like hip dysplasia and scoliosis. We want to ask about bone pain, and then understand if there's contractures or hypermobility. And then ideally, we have a good physical therapy assessment of the physical function. In our clinic, we are lucky to have both a physical therapist and a registered dietitian who sees all of our new patients with us. And so they do a full assessment, looking at not only the weight-bearing ability of these patients, help us understand the limitations, but also are very helpful in sort of working through some of the supports these kids need. And then, of course, that dietary history, taking careful attention at the bone minerals, the vitamin D, but also remembering the other macro and micronutrients. And then that review of the bone active medications and therapies that I discussed. We also see a lot of childhood cancer survivors, so thinking about the chemotherapies and the radiation therapy that they may have been exposed to as well. And then finally, that deep dive into the comorbidities, looking for any endocrine disorders, inflammation, and then any other dietary risk factors such as food allergies or tube or TPN or other big issues that we're looking for. And then moving on to clinical imaging, so a wide variety of techniques that we use in clinic. This figure is from Leanne Ward, a very nice sort of summary of the different imaging tools available to us. I'm going to talk about the first two in more detail. So dual energy X-ray absorptiometry, or DEXA, is how we assess bone density. And then increasingly, we are using vertebral fracture analysis to look for skeletal weakness in the spine. This can be done by a lateral spine radiograph. It can be done by DEXA, and in some cases an MRI. Beyond that, we get into sort of more specialized type imaging tools. You can get very detailed look at bone structure and bone strength. There is a software tool called trabecular bone score, which I'll discuss, is used mostly in adults. And then for research purposes, there is different ways of using CT scanners, so peripheral quantitative CT and high resolution peripheral quantitative CT that really give extremely fine detail of the bone, and in some sense are even like a virtual bone biopsy. These are essentially limited to research at this point, but may become more clinically available in the future. And then finally, bone scans. Technician bone scans or sodium fluoride PET scans. These are really more for metabolic bone diseases, things like fibrous dysplasia, concerns for malignancy, things like that. All right, so I want to spend some time talking about DEXA. This is by far the topic that I get the most questions about. And so if you care for any medically complex child, there's a good chance that someone somewhere has wrote a guideline recommending getting screening DEXA scans. So here's just some examples of all the different guidelines that come out and recommend DEXA scans. And this is partially for good reason. DEXA is widely available, is extremely low radiation. A single DEXA scan is about the same as a day out in the sunshine. The scans are pretty fast, so kids can tolerate them pretty well. They have to lay still only for a few minutes to get a quality scan, and it's not like an MRI. It does tolerate some movement. The approaches have been very standardized, which means that we can do these scans with very high precision as long as the staff are trained adequately. And importantly, DEXA does track well over time, and we'll talk more about how we can use that clinically. If you're interested in DEXA, or you find yourself in a situation where you are setting up a DEXA lab, the International Society for Clinical Densitometry, or ISCD, which I mentioned before, is a really wonderful resource. So their website has all of the technical details on how to perform and interpret DEXA scans, and then can really be used to guide clinical use. And then they put out guidelines every few years to talk about how to best use DEXA, and the last pediatric recommendations were in 2019. And I was a part of this, and we basically updated our guidance on what body sites to scan, and this is important. Just like any test, even though it is low radiation, you really want to understand what it is you're looking for, and make sure you're ordering the right scan when you're getting a DEXA scan. For the most part in children, the standard scan sites are going to be the whole body minus the head, as well as the AP lumbar spine. The reason that we don't include the head is that the skull, as you know, is a very strong bone and has a lot of bone mineral content. And as kids grow, the proportion of the body of the bone that comes from the head shrinks, so it can really interfere with longitudinal assessments. But then beyond the whole body and the lumbar spine, there are some alternative scan sites that can be used if there is reference data available. And these are especially helpful in children with secondary osteoporosis who perhaps have scoliosis or hardware in their back, or perhaps they have contractures and they're not able to lay still. And so these alternative scan sites that we talk about, and I'll go through in more detail, are the hip, the forearm, and then the lateral distal femur. So let's talk about the hip. So this is actually a commonly scanned site in adults, which is important. So many of our children are going to continue to have bone health risk factors once they transition out of pediatrics. So it's nice to be able to have a sense of where they've been. So when the adult doctors take over, they can understand the trajectory of bone accrual. A couple things to note about the hip. It may be more affected by pubertal delay. There's some wide variability in sort of the secondary ossification of the femur. And so sometimes it can be hard for the software to kind of pick up these edges of the bones here. It should not be used in children with hip dysplasia. That's going to give you an inadequate result. And then also does require a bit of twisting of the hip to get the proper positioning. So of course, want to be careful in using it for someone who has weak bones. Depending on kind of where you live and what type of machine you have, your reference data may be limited. There's two different main DEXA platforms, and the Hologic machines have the most reference data. And so there is hip data for that one, but not for GE Lunar. And so clinically, I do use hip mostly just in my teenagers, where I think that understanding and tracking bone density into adulthood is going to be useful. Next is the forearm. So the distal 1/3 radius is the site that is most commonly used. There's another site called the ultradistal radius that sometimes is used as well. The benefits of this is that it's an easily accessible and often the scan of last resort. So that let's say you have a kid in a wheelchair who's unable to lay flat on their back, they can actually lean over and put the forearm on the DEXA scanner, and you can get some information to track treatments. There is published reference data. Again, it's mostly for Hologic. It's a smaller bone, and so because of that, there's a bit of less precision. The data are largely limited to ambulatory children, and so we don't fully understand if the bone density at the forearm would predict a hip or a lower extremity fracture, for instance. And because it's not a weight-bearing site, sometimes you see that the bone density is actually quite a bit higher in a non-ambulatory patient compared to, let's say, a hip or a lower extremity scan site. As mentioned, I do use it, but I tend to think of it as the last resort to follow when bone accrual is not really able to be assessed from other sites. It's also a site you can see here that's rich in cortical bone, and so in the adult world, it's often used to look for the effects of hyperparathyroidism, which has a lot of bone resorption to it. And so if you have a kid with hyperparathyroidism, that's another situation where you may choose to get a forearm scan. Next is the lateral distal femur. This is a non-standard test, and so it may not be widely available in your center. It allows us to get a lateral view of the femur, as you can see here. It's important because it can be done with the leg bent, and so if a kid has a contracture, you can still get a quality scan of the lower extremity. And this distal femur is actually the most commonly fractured long bone in non-ambulatory children, so it's a useful site. It does require a bit of specialized training in order to obtain and analyze these scans. The boxes are actually hand-drawn, which is a bit tricky. And sometimes these bones are really so thin in these patients, it's hard even to draw these boxes. We'll talk a bit about bisphosphonates, but if you've ever seen an x-ray of someone on bisphosphonate therapy, they develop what are called zebra lines or metaphyseal bands. There are these areas of very dense bone that are lines that go through the bone, and they probably artificially raise the bone density. And so it can be tricky to interpret. So I do use these in children with neuromuscular disorders, and there's actually been some data out there suggesting that in that population, looking at those with a z-score of less than -5. That's going to be a pretty good predictor of fracture risk, and so someone you may want to think about treating. So increasingly, we are starting to use DEXA in younger children. So as I mentioned, it's safe and it's feasible in young children. There's a growing body of reference data available. Again, it may not be available everywhere. It does require some special operator training, and that operator training mostly is so that the DEXA techs are comfortable with younger children and swaddling babies and positioning younger kids. And so, as with anything with kids who are less cooperative, it takes a bit more time. But you can see some papers here of some reference data for kids, all the way down to age 1 and even younger. So I want to talk a little bit about the interpretation of DEXA in children then. So this is an extremely important point, and this differs from what's done in adults. And so we interpret bone density in children based upon z-scores. A little bit of math here, but your z-score is just essentially comparing your patient's bone density value to the mean of the reference population. And in this case, that would be all children or healthy children of the same age and the same sex as your patient, and then divided by the standard deviation of that reference population. Of course, assuming a normal distribution, then that's where the numbers of -2 and +2 come from, assuming that about 95% of the population is going to fall between those two values. So statistically, anything less than -2 or above +2 is going to be considered low or high bone density. So there's some trouble with z-score thresholds, as I alluded to. Number one, it is a statistical definition. And then our clinical experience and numerous studies have detailed cases of fragility fractures occurring in children with quote unquote normal bone density, which is to say a bone density z-score of higher than -2. And there's a lot of reasons for this, some technical challenges. Also, just understanding that bone density is an incomplete determinant of bone strength. It tells us bone mass, but tells us nothing about bone quality. So here's an example of a child with a femur fracture. This was a 10-year-old female who came to see me in clinic. She had been adopted from Ethiopia. She was healthy, but she had this sort of unusual fracture history. So at age 8, she broke her left femur, a mid-shaft femur fracture, just a fall from standing. And then age 10 had essentially done the same to her other side, so her right femur fractured while jogging. Femur is a very strong bone, and it's very unusual to see femur fractures in children. On exam, this child was well pairing, had white sclera, had normal dentition, maybe a little bit of mild joint laxity, had a bit of some exaggerated lordosis and a mild curve in her back. Labs were largely unremarkable. You can see there a mild vitamin D deficiency. We like to see above 20 nanograms per ml on our 25 OHD. And then her DEXA scan, which had been obtained before she came to see me, showed a lumbar spine bone density of 0.677 with a z-score of -1.3. And so, as I just told you, that falls into the normal range. And so this patient was deemed not to be, at risk. But when I saw her, thinking about that fracture history is just so unusual. You really just have to have a high suspicion for some underlying condition. And so we did proceed with genetic testing, and sure enough, she did have a mutation in COL1A2 or type 1 collagen, which is one of the genes that causes osteogenesis imperfecta. So just a good example of how you really need to rely on your clinical suspicion and history as much as your imaging data. Another example of some of the challenges of z-score thresholds, it really actually matters quite a bit which reference data set you use. So this is an interesting study out of, again, Leanne Ward's group in Canada. They took 186 pediatric oncology patients who had a lumbar spine bone density test done, and then they calculated those z-scores using 5 different reference data sets. And so you can see these are different reference data sets that had been published at the time. And you'll note that the average bone mineral density z-score was actually quite different between these, ranging from -0.5, so very close to average in one data set, all the way down to -2, which is at the very low end of the range. And so it really illustrates that you need to understand your machine that you use and what reference data set they're using. And so you can start to understand how to interpret these results. Another thing that's frustrating about DEXA scans is there's actually pretty high machine variability. And so it's really important that if you have a patient who you are following longitudinally, you have them get scanned on the same machine. And so this is a study out of the Bone Mineral Density and Childhood Study, which was 5 sites in the US that recruited healthy, typically developing children. And what you can see here is the spine and the whole body bone density z-scores at the 5 different clinical sites. And these are z-scores here, so you can see 0 and average there in the solid line. And once again, you can see quite a bit of variation between, for the lumbar spine, site 5 was above average, and site 1 here was below average. And then for whole body, even more difference. And then amazingly, that pattern is different, right? So you have site 1 that was the lowest for the spine, but was actually the highest for the whole body. So really, again, just you need to sort of understand how your machine works, and then very important to scan those patients on the same machine if you can. Just some additional pitfalls of DEXA that have to be understood. So DEXA is a 2-dimensional or aerial estimate of a 3-dimensional property of density. What this means is that it provides an underestimate of true volumetric bone density in small bones. And this, of course, is quite common for children who have either short stature or, more importantly, pubertal delay, which is common in at-risk children. And then the same thing is going to be true at the other end. So it's going to overestimate true volumetric bone density in large bones. This will be the case in children with tall stature. And so what this means is that your bone density z-scores really should be adjusted for size if a patient has short or tall stature. And this is a little bit complicated, and there's multiple different strategies. Hopefully your DEXA core or clinical site will be able to help with this. There's been essentially half a dozen different ways of doing this, and it does depend upon which software in which machine you have. They all work about the same. For Hologic, which is the type that we use, and as I mentioned, is the one that has probably the best pediatric reference data or the most widely available. It turns out that doing a method where you do an adjustment using the height age z-score was the most effective in reducing the statistical relationship with height. You can see that nicely here. So they split up healthy children into short, into average, into tall groups. And then if you just did a simple z-score based on age and sex, you can see that the shorter kids had lower z-scores and the taller kids had higher ones, and the average was average, just like what we would expect. And then so they looked at different ways of doing it, and what you can see is this height age z-score adjusted bone density z-score did the best job at removing that association. So this is what we use clinically. For the GE lunar, lumbar spine bone mineral apparent density, which is just calculated a little bit differently, has been shown to be a better predictor of vertebral fracture. And so that's what's recommended for GE lunar. And then they also have some equations for adjusting whole body bone mineral content for size that can be used. If you do have a Hologic machine, there's actually 2 online calculators that are nice and easy to use. You could just put in your bone density as well as the patient's age and sex and height, and it'll create that size adjusted z-score for you. So my institution has one here at CHOP, and then there's another one at Cincinnati that is a bit more extensive and does include those calculations for infants as well as for lateral distal femur. Both of these are restricted to Hologic machines. We do hope to be able to update them to GE and Lunar at some point in the future. I just want to talk a bit about the benefits of longitudinal monitoring. There's a concept of least significant change in monitoring time interval. These are informed by the precision and the magnitude of the change that can be detected. And so the good news is that in children, because they're growing rapidly and bone accrual is relatively high, that means that it is really possible to follow DEXA scans, at a yearly or even more frequent interval and still be able to detect differences. And so this is really important because what we're really interested in is assessing that accrual or that change in z-score. And one good way to think about it is if that z-score is getting better or higher, it means that that patient is catching up. So you might see that. And for example, that patient with ALL who had chemotherapy, had radiation, and they got cured, so their bone density may have been low after all those bone toxic treatments. But as they got cured and were healthy, they have nice catch-up accrual. The other hand, of course, would be falling further behind, and that would be when your z-score is declining. And so that would be what you would see in, for example, that patient with Duchenne muscular dystrophy whose muscle strength is worsening as they get older. The other thing that we look at in addition to the z-score is the change in the absolute bone mineral content or bone density. As I mentioned, kids are supposed to be gaining bone throughout childhood. And so if you see a child who has an absolute loss in either bone mineral content or bone mineral density, that's really a big warning sign. That's a time to start thinking about treatment. There's also some reference data out there that allows you to calculate bone mineral density velocity z-scores. This is nice, probably more of a research application at this point because the calculations are a bit cumbersome, but one day, perhaps will be available clinically as well. So I know I just spent a lot of time talking about DEXA, but I think it's important and it does require some understanding. And my take home really is that it remains an important component of the bone health evaluation. It does require some familiarity with its limitations. It is helpful in establishing a diagnosis in a child with unexplained fractures. It really must not be used in isolation to rule in or rule out skeletal fragility. Thinking about that case I presented of the child with OI. It aids in clinical monitoring, allows us to look at progression and recovery of disease. We can establish a baseline bone density and then assess for bone accrual or bone loss, and then helps us gauge our response to treatments, which we'll talk about in a bit. So my suggested best practice for DEXA interpretation is really do the best to understand your reference data and the relevance to your population. You want to consider both raw and size adjusted z-scores. Allows you to understand how much of the deficit or the excess in that z-score might be attributable to small or tall size. If possible, take a look at your images, just like you should always look at your x-rays. It's best to look at the DEXA scans to see if there's any artifacts or if the positioning looks bad. Sometimes you have like an entire arm or leg hanging off the scan, and so that's obviously going to throw off your bone density. And then really just use caution when applying the low BMD threshold. So try to avoid the use of the word normal, remembering that skeletal fragility can occur when z-scores are higher than -2. And I think a good practice is anytime you're getting a DEXA scan on someone who has some risk factors, if that z-score is less than -1, that really is enough to make you maybe take a pause and think about, are there some risk factors here that need to be looked into? All right, so just moving on then, want to talk briefly about vertebral fracture assessment or VFA. And this really is the primary means of assessing steroid-induced osteoporosis or skeletal weakness. It's very helpful in defining degree of skeletal fragility and other conditions as well. This is because it really is an important marker of skeletal fragility. And it turns out that a single vertebral fracture not only predicts more vertebral fractures, but it also predicts a long bone fracture. And so if you see this on an x-ray, that's someone who is going to be at high risk of additional broken bones. And so really it should be done routinely in children on high dose, long-term steroid therapy. Again, Duchenne is a good example of that. Also, anytime you find a low bone density by DEXA, and so when your bone density is in that low range below -2, those patients are going to be at risk of having an atraumatic vertebral. Certainly if there's any symptoms suggesting a fracture, such as focal tenderness to palpation. And then, of course, like any test, you really only should do it if it's going to change your management. Multiple different ways to do this. The ISCD and other groups have proposed using something called the Janat method. This is just a semi-quantitative way of grading vertebral fractures. And so each vertebral body is graded from 0 to 3 based on the degree of compression. And then it's also noted whether that compression is anterior, it's middle, or posterior. This is great in theory. I will tell you in practice that most radiologists don't have the time to go through and provide a grade for each one. But it's just helpful for you to think about it. And I'll even still pull this up when I'm looking at a spine x-ray to try to get a sense of how severe the skeletal weakness is. I briefly mentioned TBS, and so you may have heard about this if you've done any adult osteoporosis clinics, but it is a textural analysis of the grayscale variation in lumbar spine DEXA images. You can see what it looks like over here. The idea here is it's looking for these spaces or this porosity in the bone. And so this top scan is someone who has good bone density and has good texture, good microarchitecture. And so they're going to have a higher TBS. And this person down here, you can see, has a very porous bone, and they would have a lower TBS. And so in adults, it has been shown to predict fracture independently of bone density. So it tells us it's giving us information about something more than just bone density. In children, the reference data has been developed, but has not quite been published. So in the US, TBS is currently under review by the FDA, and so we hope that will be approved for pediatric clinical use in the near future. And then here's, as I mentioned, there's reference data published, but this actually will need to be updated. All right, so I'm going to end here talking about treatment approach to the child with skeletal fragility. So as I briefly mentioned earlier, we, of course, always want to start with optimizing our bone health. And one way to do that is from nutrition. So calcium is, of course, important for bone mineral accrual. It's not really the case, though, that everybody should take calcium supplements. And so we really only want to be recommending calcium supplementation as indicated by dietary and/or laboratory evaluations. And the reason for this is that unnecessary supplementation can actually worsen your risk of hypercalciuria, which can lead to nephrocalcinosis and kidney disease. And then in adult studies, higher calcium use has been associated with other forms of cardiovascular disease, probably also related to the issues with the kidney. Vitamin D supplementation is indicated in many patients. Of course, we get vitamin D from the sunshine. And so, you know, even in places with sunny climates, nowadays, many children don't spend enough time outside in the sunshine. And if they're wearing sunscreen, that's going to block the activation of vitamin D. So for the most part, we do recommend vitamin D supplement in children at risk. The dosing targets really need to be sort of individualized. We talked a bit about the population guidance of achieving a 25 OHD higher than 20 nanograms per ml or 50 nanomoles per liter. And that's going to be sufficient for most patients. Although if you're worried about nutritional deficiency, let's say it's somebody with celiac or someone who requires post-pyloric feeds, then you're going to want to do some more labs to help understand maybe how much calcium and how much vitamin D they need. And those labs would include an alkaline phosphatase, an intact PTH, looking at the urine calcium creatinine level. And then you may end up giving higher doses than you would otherwise. And then we want to try to do our best to optimize bone health from a weight-bearing status as well. So disuse is going to favor bone loss, while weight-bearing is going to favor bone formation. That's shown nicely here in this figure, the schematic sort of in the middle here. So normal, you're going to have sort of a balance of weight bearing on bone. And what we're trying to avoid is this disuse category here. And so this is someone who's essentially getting no weight bearing at all, and they're actually going to lose bone density because there's going to be an increase in bone resorption and a decrease in bone formation. At the other end of the spectrum, you can actually build bone with excessive weight bearing. This is really not practical for most of our kids. And so if you look at studies that have tried different exercise interventions, I think many of them will be quote unquote negative studies because they didn't find the intervention improved or increased bone density, but that really isn't our goal. Our goal really is to maintain bone density for these patients. And so that's where we're going to work closely with our physical therapist and our orthopedist to try to come up with a plan using standards or gait trainers that's going to help keep them weight bearing and do it in a safe manner. Of course, many of these kids do have physical limitations, things like contractures. And so that, of course, benefit has to be balanced against whatever increased risk of fall and discomfort that would come along with the regimen. And then I'll end here talking about pharmacotherapy. So bisphosphonates. So these are the most widely used class of anti-osteoporosis medicines in children. Traditionally, the use in pediatrics has followed the principle of secondary fracture prevention, which means that treatment is typically not considered until after that first fracture and that situation where spontaneous recovery is not expected. And the reasons that this has been the historical way of doing this is that there hasn't been many clinical trials done in children. There's actually no medicine, no osteoporosis medicine that's approved, at least in the US, for osteoporosis. There are some short-term risk factors to the use of bisphosphonates, and then there's just some lingering uncertainty related to long-term effects and questions for how long they should be used. So these are strong medicines, and so we do have to think carefully about the potential side effects. The acute complications include hypocalcemia. So what happens is you shut off bone resorption, and so you essentially eliminate a source of calcium into the blood. And then with the first infusion, many patients get what's called an acute phase response. So they get fevers, they get myalgias, they get potentially some hypotension and some GI distress. And then they are excreted through the kidney and eliminated through the kidney. And so they have some nephrotoxicity. And so we do want to avoid them in patients with severe underlying renal disease. They have been widely used, however, and there are several papers that have looked at the rates of side effects, and one of these is our papers, and one comes from Cincinnati. And one thing that you'll notice is that the rates of adverse events were significantly higher in children with secondary osteoporosis versus those with primary osteoporosis. In our study, 42% of those with secondary fragility versus only 13 in OI. And the reason for that is, of course, that I think the children with secondary fragility are just more medically fragile and more complicated. I do want to highlight, though, in both studies, the vast majority of these adverse events were mild and they can be managed. So to that end, it really is our thought and the thought of the field that bisphosphonates can be safely given to children with proper precautions. So that means you want to make sure that you're screening for renal insufficiency and doing your best to make sure that vitamin D is adequate prior to treatment. What we do is we give prophylactic calcium, and then for first infusions, we give calcitriol or active vitamin D for about 3 days after the first infusion to guard against the hypocalcemia. We also recommend a dose of an antipyretic. We use acetaminophen right before the dose, and then for about 24 hours. And then for the most severe, the most complex patients, so let's say those with inflammatory bowel disease, where you're worried about calcium malabsorption, or a patient with uncontrolled seizures, we actually will admit them to the hospital and monitor. But that's actually a minority nowadays, so we probably do over 90% of our infusions, even first infusions, as an outpatient. There's been some recent studies. These are actually the first randomized controlled studies of the use of bisphosphonates. This was looking at zoledronic acid. This is the most potent of the bisphosphonates. And so there's 2 of these. The first was by Leanne Ward and colleagues. Again, this was a secondary prevention study. So everyone in the study had had at least 1 fracture. And so they randomized 18 subjects on steroids to either zoledronic acid or placebo, 16. And then what you can see here is the group who got Zol, the gray line here, had a significantly greater increase in lumbar spine bone density over 12 months. That was also true if you did a height adjustment. the study was relatively small, so they weren't powered to look at fractures, although they did note that nobody in the treatment arm had a new fracture versus 2 in the placebo arm did. And then the same year, actually, there was a very similar second study that came out by Zachrin and colleagues. This was focused specifically on children with Duchenne muscular dystrophy on steroids. This actually was a mix of a primary and a secondary fracture prevention, so not everyone had a fracture who went into the study. They ended up getting 2 years of Zol, and they didn't get a strict placebo. They got just calcium and vitamin D was the comparison group, and so 30 in each group. And you can see the results are actually very similar. So in this case, the treatment group is in the solid line and the calcium and vitamin D only in the dashed line. And again, a nice increase in that bone density over 12 months. And then you can see that increase in difference was maintained over the course of the study. And then when they looked at the change in the bone mineral density Z-score from baseline, more apparent even here. So you see that those in the treatment arm had a positive increase in bone density Z-score, so they were catching up, if you will, whereas those who got the calcium and vitamin D had a loss in Z-score, so they were falling further behind. Again, not powered to look at fractures, but there were differences, numeric differences. So there were 4 fractures in the cohort that got Zol versus 7 in placebo. Beyond that, there are oral bisphosphonates you may have heard of. So alendronate or alendronate or Fosamax. These are used commonly in adults. We generally think about them as second line in children and use them mostly for patients who can't tolerate IV zoledronic acid or other IV formulations. The reason for this is that they're actually very poorly absorbed. And because children have higher bone turnover, they sort of need a higher effective dose, I think, than adults do. And so I think this is perhaps why they don't work so well. They also have significant GI side effects, and it does require that the child be able to take it on an empty stomach with a full glass of water and be able to sit up and nice and tall for 30 minutes after to avoid reflux and esophageal damage. Typically, they're given once a week. Increasingly, they are being used in some of these medically complex patients, again, those with Duchenne, where maybe they have some early benefit is more of a prophylaxis rather than a treatment. But to date, there's been no head-to-head comparison between oral and IV bisphosphonates. So just my best practice for how to use bisphosphonates, the way I kind of approach a child who I think is at risk is thinking about the phases of treatment. So that first phase is going to be the monitoring phase. And then we're going to move on to treatment stabilization. So when we decide to treat, and then there's a treatment maintenance phase. So continuing on treatment. And then at some point, we can't keep these medicines on forever. We're going to talk about stopping and then ongoing monitoring. And so there's a very nice paper by Peter Sim and colleagues that kind of lays forth some consensus guidelines for the use of bisphosphonate therapy in children and adolescents and sort of walks you through how you might do this. Generally speaking, as I mentioned, the IV formulations are recommended. Dosing protocols do vary. I want to quickly talk about some emerging therapies that you may have heard of. So denosumab. So this is an anti-rank ligand antibody or rankle antibody. So this is an extremely potent anti-resorptive. So again, eliminates osteoclastic activity. Bisphosphonates, the way that they work is they actually kill off the osteoclast, and so you reduce osteoclast number. But that's a very transient phenomenon, and right away, as soon as the bisphosphonate is out of the system, you get differentiation and the osteoclasts come back. For denosumab, essentially what happens is all of the osteoclast activity just gets arrested in the setting of the rank ligand antibody. And so you get a sustained, essentially absence of all osteoclastic activity. So very potent. So potential benefits is that they're given subcutaneously as opposed to IV, which of course would be nice. There's no acute phase response and they're not cleared by the kidney. However, what we've learned in children, more so than adults, but in some adults as well, that there's a risk of this severe, potentially life-threatening rebound hypercalcemia. And I think the idea here is, again, because all those little osteoclasts are just sitting there kind of quiescent and put to sleep, once that rank ligand antibody is taken away, then they all get activated. And so you sort of have this excessive bone resorption. And in children, that actually leads to really significant hypercalcemia. In adults, it typically manifests more as bone loss. And so it's really tough. This was a patient of ours. This was an 18-year-old who was on denosumab for a giant cell tumor. So that's one of the indications this medicine is used commonly for. And these are his calcium levels here and his creatinine levels. And normal between 8 and 10. You can see stopped denosumab August of 2020. Calcium creatinine levels looked good for almost a year, and then bam, marked increase in his calcium, and then acute renal failure essentially. So came in very sick. Was able to get treated with hydration and then bisphosphonates. Didn't need to go on dialysis, but unfortunately never had complete resolution. Kidney function never got back to normal, so ended up having permanent renal insufficiency from this treatment. So for children, then really, we're going to highly limit its use to those with giant cell tumors and other bone lesions that are very aggressive. These doses are higher than have been used for osteoporosis. There's been a couple of people, in some case reports, using it in OI. So perhaps there's some protocols that could be developed. People are thinking about doing more frequent dosing, so every 3 months. Perhaps alternating denosumab with a bisphosphonate to try to control that osteoclast activation. And then perhaps there'll be less rebound in some of these low bone turnover states. So there was a study looking at their use in patients with steroid-induced osteoporosis. Although interestingly, what happened is that they also got rebound hypercalcemia. It just was much later than children with OI or other conditions. So more to come on denosumab. And then anabolic agents. So this is a area of treatment that we're actually very excited about. So these are bone building agents. In adults, they've been available for some time. You may have heard of recombinant parathyroid hormone, either as teriparatide or abaloparatide. And then the anti-sclerostin antibody called romosozumab. And these promote bone formation in adults and have been used to treat osteoporosis for probably about a decade now. And so these are very mechanistically appealing to children with low bone formation. Some things to worry about, of course, with side effects. Initially, there was concerns that the recombinant PTH agents might increase the risk of bone cancer. And so there was actually a warning against their use for many years in children based on some animal data where animals receiving very, very high doses of teriparatide had a high risk of osteosarcoma. That warning has since been removed because there's been no reports of osteosarcoma after a decade of use. And then for anti-sclerostin antibody, the major concern is cardiovascular complications. And so there's been some questions about, would it be safe to start using these agents in younger children who potentially have that longer exposure and cardiovascular risk? One consideration for both of these types of drugs is that the duration of effect is limited. So in adults, it seems that the benefit on bone density does wear off after 1 to 2 years. And so most likely it would require some cycling of an anabolic agent followed by an anti-resorptive agent. As I mentioned, people are using these, however, and so this was the first paper looking at the use of teriparatide in children with Duchenne. This was just 6 subjects. 4 of them did have open growth plates. They had all failed treatment with bisphosphonates. What they saw is that the bone density did stabilize, so there was no significant gain in bone density, but then they weren't losing bone density. So again, sort of a mediocre response. And then somewhat disappointingly, they had sort of mixed effects on vertebral fractures. I think it turns out that teriparatide isn't going to be great for healing vertebral fractures. They show that in this figure here. What they're doing is showing the different fractures of the different vertebral bodies, T9 through L4, whereas a green triangle improved, a blue circle was stable, or a red triangle got worse. And you can see really a mix there. And I think probably there's just so little bone in these osteoporotic vertebral bodies to be worked on, which perhaps is why we're not seeing so much benefit there. And so I think this is just another example of where alternating a therapy with an anabolic and an anti-resorptive is probably where we need to go. And then finally, the anti-sclerostin antibodies. So setrusumab is one that's currently in clinical trials in children. So there's a study called the Orbit study, and then another one called the Cosmic study that are looking at this in children with OI. And so the phase 2 study is fully recruited, and actually both studies are now fully recruited. And they did show some data at the bone meetings last fall. So this is again looking at change in lumbar spine, bone mineral density Z-score, and these are two different dosing arms. But what you're seeing over the course of 12 months is a really dramatic increase in bone density, probably even a bit higher than what we see for bisphosphonates. And they did see a decrease in the annualized fracture rate from 0.7 to 0 fractures per year over this course. So very promising early data. This medicine is given as a monthly infusion, so that's not super great. So you can imagine many children may not love the idea of coming in once a month for an infusion, but potentially it's going to be another tool that we're going to have. So we look forward to learning more about it. And then finally, just again, want to emphasize the point that treatment is not always indicated. I keep going back to the children with ALL, and that's partially for good reason. So when I was training 15 years ago, we would routinely treat patients with ALL who had a vertebral fracture. So kids with ALL get very high dose steroids as a part of induction chemotherapy, and vertebral fractures are quite common. And so it's not uncommon to have a patient whose spine looks like this on ALL after the first couple months of treatment. And then what we learned over time is that as long as these kids aren't in pain and they respond well to chemotherapy and they improve and they're cured, like many of them are, their bones will reshape on their own. So here's an example, from the age of 5 to the age of 10, without any interventions, you can see vertebral fractures that slowly remodeled, and by the time that they were age 10, the spine looks perfectly normal. And so that's why it just is so important, because these medicines do have side effects and do have risks. If you have someone who has a transient risk factor, that risk factor goes away and they can still grow, then you can hold off on treatment. So that's one of the lessons that we've learned. So then to summarize here, the population of children at risk for severe skeletal fragility is quite heterogeneous. The field, and I would urge you really to sort of move away from a bone density centric monitoring approach. Really want to use our clinical judgment to understand risk for skeletal fragility, and then increasingly think about using tests like the vertebral fracture analysis for patients on steroids. Important to remember that a single vertebral and/or minimally traumatic long bone fracture should prompt consideration of bisphosphonates in those patients at high risk. It can be avoided in those kids with good prognosis, like that kid with ALL, but really should be used aggressively in patients with a poor prognosis and a progressive disease like Duchenne. And then ultimately would like to see us move toward a strategy of primary fracture prevention, and then increasingly, hopefully, get to use these bone anabolics to help build bone as well. So with that, I will wrap it up. And I understand that you can't ask questions, but I did offer to share my email with your course leaders. And so, please feel free to email me if you have any bone health related questions.
Well, doctor, on behalf of Soy Pediatría Bosque, we thank you for this talk and joining us today. It was very interesting, and I think it's very important for us to know about the clinical approach of these children. Muchas gracias a todos por acompañarnos el día de hoy. Espero que tengan buena noche. Como dijo el doctor, pues si tienen alguna pregunta, igual él deja ahí pues todos los datos, también si se quieren comunicar con él. Y que tengan buena noche. Gracias a todos.
Thank you.